So thank you everybody for joining us today. We are here, we're just really honored and privileged to have Dr. Anna Wilson joining us today to talk some, as you see here, about intergenerational transmission of risk for chronic pain and why parent pain matters. This is part of our center, we have a NIDA Center of Excellence that's focused specifically on parenting in the context of opioid use. And so as part of that center activities, one of our roles, in addition to conducting research and training activities, is to host webinars such as this nature and offer free continuing education and continuing medical units for those in our local community, but also throughout the United States. So just a forewarning that at the end of this webinar, you will see a pop-up on your screen that will ask you if you would like CEUs or CMUs. If you see that and you're interested in those, please click yes. And I believe that you'll then down the road receive something from Ashley Nash that certifies your participation and gives you those CEUs. If for some reason you miss it, please just respond to me or to Ashley Nash and we can get you set up there. So with that, I do want to introduce Dr. Anna Wilson. Dr. Wilson is as you see here, associate professor in pediatrics at Oregon Health and Science University. She's really widely known for her research in pain. And as those of you who are attending, we know that pain and pain management is part of what's the challenge of the opioid epidemic that's been hitting our country and internationally for the last several years. Dr. Wilson originally received her PhD from University of Washington, and I won't give a date on that just so that we don't age anybody here, but
thank you for that
training in this space with another institution that does a lot of excellent research in substance use. So thank you so much for joining us today, Dr. Wilson. I'd love to turn it over to you, and you'll probably speak for the next 40 minutes or so, and then we'll have some time if people would like for open Q&A. But if things come up for you during the presentation or during the talk, please feel free to use the Q&A button at the bottom of your screen, and we may respond to some of those online or else hold them till the end depending on the nature of the question. So with that, I will turn over to you, Dr. Wilson. Thank you so much for being here.
Great. So first I'll have to figure out what makes my slide go forward here. Hold on one second. Okay. Sorry, I'm just trying to figure out how to actually go forward. So I want to start with just some disclosures. So I am associate editor for pediatric submissions at the Clinical Journal of Pain, which is just a way of me saying if you happen to have papers about pain in children, we would be happy to review them. And I want to also start with just an acknowledgement that, you know, as in addition to sort of the social and cultural and sort of backgrounds that we all bring as individuals to our work, I think that pain in particular is informed by our own experiences. So I think it is foolish as scientists if we sort of believe that we are operating in a way that is ignoring that. So I think we all come to thinking about pain from personal experiences. And I just like to acknowledge that. I am also a parent, and all of those things kind of come into play when I'm thinking about my area of research. So I'm just going to talk briefly about pain as a problem in adults and children in the US, and talk about chronic pain and intergenerational risk and some models that we have of that. We'll review some work and findings from the maternal chronic pain study, which is a study that we have going on here about moms with chronic pain and their children, and then talk a little bit about pain and substance use and a study that we have that looks at opioid use in young people, and then some discussion of the overlap between pain and substance use and potential shared mechanisms. So I want to first start with a definition of what pain is. So the International Association for the Study of Pain recently updated this definition, which had been in place since 1979. And in 2020, we got a new definition of what pain is. So pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So we really do think about pain as being the definition of it inherently has an emotional component. And this definition also came with some notes that are particularly important for behavioral and social science researchers. So the folks who developed this definition wanted to also point out that pain is a very personal experience that is influenced by biological, psychological, and social factors. A person's report of an experience of pain should be respected. Really, self-report is the only way that we have of assessing pain at this point in time, although we certainly have biological and neurological correlates of pain. They also note that pain usually serves an adaptive role, but it can also have adverse effects on function, and we'll talk a little bit about that today. And then my favorite note is, through their life experiences, individuals learn the concept of pain. So this is the definition of pain in general. Most of what we'll be talking about today is chronic pain. And there are many, many, many terms, diagnostic terms, research terms for a lot of different chronic pain conditions. Most research on chronic pain conditions is focusing on what we would call chronic non-cancer pain. This is pain that persists past normal healing time and lacks the acute warning function of nociception. So we kind of think about chronic pain as pain that's no longer useful as a warning signal. Depending on what research area you come from, we would define chronicity as being something that persists for 3 to 6 months. And the prevalence is quite high in adults, so 18 to 34%, depending on the condition and the study that you look at. And we know that chronic pain accounts for 15 to 20% of all physician visits. This is an illustration from one of the first patients who I saw when I started working in the pediatric pain management clinic here at OHSU. And Ashley had pain in many of her joints. This started when she was about 12, and she had been really thoroughly medically evaluated with a lot of normal test and exam results. And when she came to the pain clinic at 16, her pain had become fairly widespread. And as you can see in her drawing, it's quite specifically located. And was really part of her life on a daily basis. So she had very few days when she had no pain. And people are often surprised to know that kids experience this type of chronic pain, but Ashley is not alone. So the burden of pediatric chronic pain, we know that about 18% of kids ages 6 to 17 get treatment for a chronic pain condition in a given year, and a smaller portion are experiencing what we would consider to be moderate or severe disability due to pain. And this is costly in terms of healthcare expenditures. So 19.5 billion is the estimate, which is really on par for kids with ADHD and twice the cost of asthma. So we also know that the burden of chronic pain that kids and their families experience is not just this economic burden. It really has an impact on a lot of different areas of functioning and increases risks for a number of poor outcomes in kids and adolescents. And when I started seeing these patients clinically, one of my first thoughts was that in the medical system, we were coming to this problem far too late in kids' lives. And it was really after pain had already become chronic and was having a huge negative impact on their lives that we were showing up to help. And we also know that many adolescents who experience chronic pain, so 30 to 40%, have pain continue as a clinical problem in their lives in adulthood. When we look at the impact of chronic pain on adults in the US, it is enormous. So about 50 million adults have chronic pain conditions, and the cost is much larger. So we had the most recent data we have from this 2019 survey found 50.2 million, so 20% reported pain most days or every day. So one huge first take-home message that I want to get across is that any sample of parents you are working with includes parents with chronic pain. And I think you can look at this from just sort of this lens of the prevalence of pain in adulthood. We also know this from working with looking at various pediatric samples. So if you ask parents within pediatric samples whether a parent in the family has pain, you get estimates anywhere from 20% up to about 60%, depending on the kind of sample that you're looking at it. So whether we assess it or not, whether we look at the impact of it or not, many of the kids that we are working with and the pediatric child samples we're working with are experiencing parental chronic pain in their lives. But what do we actually know about the impact of parents' chronic pain on children or on parenting? We know that the presence of chronic pain conditions in parents increases risk for children. And this was the first systematic review in this area, and we really showed that these offspring experience higher pain, higher internalizing and externalizing problems, and lower social competence. We also know that from family linkage studies that parent-child pain associations are not fully explained by genetic similarities. So this idea that we know family pain models and shared environmental factors are important in the origin of chronic pain. And a lot of what we know about this sort of intergenerational transmission has come from samples of adults and kids with abdominal pain. So we know from some ongoing samples of comparing moms who have IBS to moms who do not, that the children of mothers with IBS have more frequent stomach aches and clinic visits themselves. In the early days of this research, we had this terrible term solicitousness, which really is just inadvertent reinforcement or sort of overly protective behavior from parents. And that is related to higher child pain severity and school absences. And we see that in a number of studies that the sort of presentation of the type of chronic pain that happens in families is similar in parents and children. And we also know that having a parent with a chronic pain history is related to poor long-term outcomes in young adulthood for individuals who had a history of functional abdominal pain as children. So this is just sort of the state of where things were in terms of understanding of these intergenerational processes when I started working in this area. And I want to go back. So I just pulled out a couple of my favorite quotes from papers. And this is my mom at the beach. Health beliefs and healthcare utilization patterns tend to run in families. And there are multiple independent factors or behavior patterns that may be passed or shared between parent and child that contribute to the clustering of illness within families. So I want to go back to Ashley for a minute. So I met her in probably 2005, 2006. And a few years ago, just before COVID, I ran into her at the Starbucks in the lobby of the Children's Hospital. And she immediately recognized me, caught me up on her life, and said she's, still experiencing pain, but is managing it pretty well. And she was there with her two kids who are 2 and 4 years old. And she's taking her 2-year-old to her well child visit because Ashley is now in her 30s. So aside from making me feel super old, it was a really clear reminder for me that the kids who we see who have chronic pain today are going to be parents themselves in the blink of an eye. So this part of development is quick. So the things that we're doing to help address pain in childhood is also helping address pain in the next generation. So we had some information about maternal chronic pain and parenting that was a really just very quite pain specific when I first started working in this area. So we knew that moms who have chronic pain, this is associated with differential cognitive, emotional, and behavioral responses to child pain experiences. So moms with pain have increased pain catastrophizing and worry about their child's pain. They tend to engage in higher protective behaviors that may inadvertently reinforce pain, and they may be more sensitive to, there was one study suggesting they might be more sensitive to children's pain and distress. We also know that there are a lot of other factors associated with chronic pain that are known to impact parenting. So we see higher rates of ACEs in adults with chronic pain. Children of moms with chronic pain have higher exposure to comorbid maternal depression. And chronic pain also has this detrimental financial impact on families and just an increase in family stress in general. There was really no data on general parenting. So we hadn't really looked at whether parents with chronic pain tended to have more warmth or more inconsistency or any of those kind of traditional parenting dimensions that we might be interested in, just hadn't really been examined. So we had some qualitative study that was part of some preliminary data from my K-23 that showed parents with pain had perceptions that they were less consistent and worried about being less warm and less available for their kids and being able to participate less and have lower levels of involvement. But that was really from qualitative data. So we started with developing a fairly comprehensive model of potential mechanisms that may sort of account for this relationship between having a parent with chronic pain and having these poor child outcomes. And I worked with Amanda Stone on this paper. She was briefly a fellow in our lab and is now on faculty at Vanderbilt. And we really sort of fleshed out all of these different potential pathways that can impact things that are known child vulnerabilities for developing chronic pain. And the things in this blue circle are the mechanisms that I'm most interested in and that our studies have been designed to assess. So I want to highlight some findings from projects that have come out of our lab in the past few years with a focus on these social learning and parenting factors. So there are all of these different aspects of learning pain. And I think coming back to that piece of the definition of pain, thinking about the family context, we certainly have genetic and neurobiological risk that is related to having a parent with chronic pain. We also have observational learning processes. We have how parents respond to children's pain in just everyday acute pain experiences. We also have the overall family stress environment and these processes around fear and avoidance learning. I think that there had been a lot of assumptions in the field that about these things and how they work in families where parents have chronic pain, but very few studies starting with parents and then moving towards kids' outcomes over time. So the maternal chronic pain study is designed to test some of these intergenerational mechanisms. And the study recruited 400 mother-child dyads who were 8 to 12 years old at baseline. And this is just a map of where participants came from. So we recruited them from 3 West Coast adult pain clinics, one here at OHSU, one at Stanford, and one at UW. And then also recruited through online advertising that ended up getting us folks from all over the country to participate. The study had 3 data collection points, which were annual, so we can start testing some of these mechanisms of how risk is conferred longitudinally. And at enrollment, we conduct a family history interview, and then at each time point, moms and children complete a pretty extensive battery of questionnaires online, as well as a 7-day electronic diary, which will help us understand more about the daily impact of variations in between mom and kid functioning. And then we all know what happened in 2020 that sort of threw a wrench in everybody's perfectly designed data collection. So one of the things that we were interested in doing as part of this study is thinking a little bit about the multidimensionality of what maternal chronic pain means. So you can see that for the participants in our sample, they have a range of diagnoses, the most common being fibromyalgia and back or neck pain. But as is the case with most adults with chronic pain, the majority of the sample, 74%, has 2 or more pain problems. And this is just a sort of heat map of the locations of a body map that we use to assess pain location. And with this map, which does have many little small parts, and the front and the back, the average number of locations that people selected was 10. So these moms are 40 years old. Most of them have been in pain for almost 20 years on average, although there's a pretty big range of when that onset happened. 27% had their chronic pain start in childhood. This is a highly educated sample that is mostly white. 17% is receiving disability due to pain, and 42% have an opioid prescription that is either as needed or they are on long-term opioid therapy. This is just the results from the first 2 years looking at kids' pain frequency. So at time 1, 39% reported that they had pain once a week or more frequently. That increases to almost 43% at time 2. So, and again, they're 8 to 12 at year 1, and then 9 to 13 at year 2. But we see that 39% of the participating children had an increase in their pain frequency from that first year to the second year. And this looks really similar when we look at pain intensity. So this is just how intense is your pain, usually on a 0 to 10 scale. So we see the mean at time 1 is 3.3. It goes up a little bit from the mean perspective at time 2. And again, it's about 44% that have an increase in their pain intensity across that year. We are, of course, not really that interested in the mean increases. I think what we're really interested in is differentiating whose pain increases and whose pain goes down over time, and what are the factors within the family that we could potentially be intervening with that might be predicting those trajectories. We also, most of what we've known so far about maternal or paternal or any kind of family chronic pain has really looked at that as a binary variable. And I think that part of that is just the nature of the epidemiological data that has been used to look at these things. But we know that having chronic pain and parents having chronic pain is really a multidimensional risk factor. So it's not that kids are receiving this exposure to just a parent having pain, and that's sort of like a checkbox that you have. So one of the things we've been really wanting to do within the maternal chronic pain study is think of different approaches for characterizing what maternal function is like. So one of the ways that we have done this is looking at using promise measures and looking at differences and in some cases sort of similarities in mom's presentation based on their pain grade. So there is a system for grading the severity of chronic pain. It sounds depressing, but basically it includes both the intensity of the pain that patients are reporting, as well as the level, considering the level of pain interference, and sort of puts patients into these different grades. So this is just looking at physical function, sleep disturbance, fatigue, social roles, anxiety, and depressive symptoms by pain grade. And you can see that for most of these things, the function in this group of moms goes along with pain grade. So moms with a higher pain grade or have lower function. And you can also see the promise measures are T-scores. So you can see that sleep disturbance and fatigue are above 50 for all of these participants, and the higher the pain grade, sort of the more severe that symptom area is for them. And there's similarities with anxiety and depressive symptoms. And then you see the reverse in the physical function and social roles, where 50 is the population norm. So these moms really all have some notable impairment in physical function and in social functioning because of their pain. So we have also done some work using the Promise 29 to identify subgroups of moms with chronic pain. So moms in our sample reported on all of these different dimensions, and we use some latent profile analysis to identify these sort of naturally occurring subgroups of moms. So for all of these domains on the left in this chart, higher is worse. And then for social roles and physical function on the right, lower is worse. So we identified 4 subgroups of moms. The light blue is really the group that's functioning best. They have the lowest symptoms overall and really pretty typical levels of social and physical function. And then the pink is the worst group, functioning group, with sort of the highest symptom scores and pain interference across the board, and then the lowest social and physical function. And then the 2 groups in the middle have sort of these moderate function groups, but they are differentiated with anxiety and depression symptoms. So one group has elevations in those, and one group is really within the normal range. So once we had identified these subgroups, we then looked cross-sectionally at differences in child outcomes. And this is all data from baseline from the MCP study, and we didn't find any differences in kids' pain based on these profiles, but we did find that the children of moms in the sort of best functioning group had significantly lower somatic symptoms and significantly less pain catastrophizing and worry about their own pain. And then, as you might expect, the two groups where the anxiety and depression symptoms were lower, those children also had lower depression symptoms. So we're seeing impacts of mom's function beyond just the pain itself on child outcomes, even just within the time one data point. So one of our next steps is sort of looking at these trajectories for kids all the way across to time 3. And then one other project that I wanted to share. So this is being led by Jackie O'Brien, who used to be at the U of O and is now a postdoc working with us. So this is preliminary and is still under review, but we know that from previous work that having chronic pain impacts pain-specific parenting. And this project was our first foray into looking at what does general parenting look like in moms with chronic pain. So we were interested in sort of profiling parenting within these moms, and then also looking at the impact of that over time in predicting kids' adjustment. So for this project, we have measures of inconsistent discipline, positive parenting, or warmth, and then we have a measure of poor supervision, and then we have pain catastrophizing and pain overprotectiveness. And we ended up identifying 4 groups of sort of these parenting profiles. The first group, in really great news, is the largest group within our sample and is really average parenting, which is great. We all know average parenting is wonderful. So these were moms who have really just pretty typical and positive parenting styles overall, and also are not engaging in a lot of catastrophizing about their child's pain and protectiveness around their child's pain. We also identified a group that has just poor supervision, but no elevations in pain-specific parenting, and another group that has elevations in pain-specific parenting that is in the direction that may be sort of contributing to kids' pain over time. So, and then we also identified a very poor supervision group, which is a really small set of parents. So I think it was really interesting to think about parenting from this sort of profile approach, because I think we've had a tendency in this area to think that having chronic pain is going to impact parenting the same for all parents. And I think that this is really just showing that it's not the same for all parents, and that some parents have specific potential challenges or potentially areas that might be targeted with preventative interventions. And also, I think there's really good news for parents who have chronic pain, that many of them are parenting quite well, despite worries that they might have about their parenting. So we then looked at how maternal pain impacts child psychological outcomes over the course of 1 year. And I swore when I was a trainee that I would never put up a slide like this, so I'm sorry. Um, but you can see that we have this latent variable of maternal pain that includes mom's pain intensity experiences and interference. And we see that maternal pain, the more intense and interfering that pain is, the worse pain is. These moms are reporting higher levels of positive parenting. They're also reporting higher levels of pain parenting, pain-specific parenting. So more catastrophizing about their child's pain, more protectiveness around their child's pain. And then we do see an impact of that pain-specific parenting on child psych outcomes, but this is really mediated through kids' distress tolerance. So we see that there is, and I think this is really interesting to think about from a learning perspective, that these are kids who are probably having more pain-related learning opportunities in the household because their parent has pain. And there may be just a generally higher level of focus on pain, but how their parent, mom, is responding to their own pain experiences is associated with children's ability to tolerate distress generally, and really is relating to psychological outcomes. So it's an interesting, I think it's an interesting pattern of results, and also an interesting way to think about how we could intervene on parents' own distress tolerance and cognitions around their children's pain in a way that may have beneficial outcomes for kids' general psych functioning over time. So, so there are lots of next steps for the maternal chronic pain study. So what about dads and partners and step parents and other pain models in the home? So I think when you work clinically with kids who chronic pain, you sometimes find out that they are really close with other family members who have had chronic pain for a long time. So thinking more broadly about pain models in the environment, I think, is an important next step. And we do have information about this for our families. Thinking about the developmental timing of exposure and onset of maternal pain is also something that I'm really interested in, because we do know that the subgroup of moms who had pain onset in childhood has more severe pain, but thinking about from the child's perspective, is that necessarily going to lead to more negative outcomes for kids or not? Perhaps it's something that they've been living with all their lives and it's more of a sort of status quo. So thinking about when in development the pain problem has started is interesting. There is a need to increase racial and ethnic diversity of samples of parents with chronic pain. I think this is also true in pediatric samples of chronic pain. A lot of our research has focused on individuals who are receiving tertiary care from pain clinics, which tends to be not very representative of the population. And then examining family history density. So we're able to look at first and second degree relatives of pain who have pain conditions, and really sort of take it a step beyond just, do you have a parent with pain, to sort of have an estimate of heritability risk. And then there's the challenge of just incorporating COVID times into what the analytic plan is for our time 3 data. We did some supplemental data collection around COVID, and from that, we know that these moms experienced some positive changes in functioning during COVID. So really disentangling kind of how we're going to look at that statistically is one of our next challenges. So I want to really briefly talk about pediatric opioid prescribing and tell you about a different study. I'm not going to spend much time talking about results from it, but I think that this is going to be relevant for this group, and also just is an area where we think about also that transition from childhood to adulthood and how that looks in the course of chronic pain and how that looks in the course of substance use. So I think from a medical perspective, from just a sort of ethical perspective, there's really it's really important to manage acute pain in childhood. So we know from lots of research that poor acute pain management increases risk for development of chronic pain in kids. High intensity pain in medical settings also increases risk for pediatric medical traumatic stress. And you can infer from that research that high intensity pain probably contributes to trauma experiences for kids in lots of settings. And we also know that early pain experiences can shape neurobiology in a way that sort of primes the nervous system for high pain in the future. So there's a whole body of research on the number of painful procedures that babies in the NICU receive really rewires their nervous system and makes it quite distinct from a typically developing nervous system in terms of pain. So we have this need to manage acute pain. And then we have this misuse and addiction risk. So by the end of high school, about 25% of kids have received an opioid prescription. The vast majority do not misuse these medications, but it is a frequently misused class of prescription drugs. And depending on the year that you look at, it's almost 5% of 12 to 17-year-olds receive a prescription opioid in a year. This has not changed much with our providing sort of changes in prescribing guidelines, and that is in part because there is a pretty stable set of medical procedures and conditions for which opioids are indicated, and kids are still consistently receiving opioid prescriptions as part of typical medical care. And we do know there is this risk of misuse in adolescence transitioning into bigger problems with substance use down the road. I really think that this is a concept that I think in the medical field, we really think about it like it's an either or sort of thing, which is, as most either or thinking, unhelpful. So I really think that from a behavioral perspective and a learning perspective, I think about kids learning in all of these pain experiences, whether they have an opioid or not. So kids are learning in the context of acute pain, whether pain is something to be feared. We know pain rapidly teaches fear because it's a very strong stimuli. And they learn that fear in the context of a social environment. They also are learning how taking a pill makes them feel. And that immediate pain relief can be a very powerful learning experience for kids as well. And we also know that individuals who have that immediate positive kind of hedonic effect may be more likely to have subsequent use or misuse. And kids are also learning self-efficacy or not around pain. So how much am I able to manage or impact my own pain experiences? So we have an ongoing study that I'm just going to quickly describe, that is the ROAM study, where we're enrolling kids and adolescents and young adults who get an opioid prescription for acute pain. And we're really interested in looking at within that acute pain window, are there patterns of how kids use or don't use these opioids, or are there patterns within their pain experiences or other pain management experiences that are going to be predictive of subsequent misuse, subsequent other substance use, and subsequent pain chronicity? So I think from a developmental lens, when I'm thinking about young adults, which I mean, I think we extend adolescence now to age 25, so emerging adults. We know that there are a good portion of those young people who are experiencing chronic pain, about 25%. And we also know that many of them are soon to become parents, but it's also a time in development when people are not engaging with medical care nearly as much. So when we do have a young adult have an interaction with the medical system that leads to an opioid prescription, it is, I think, really an opportunity to implement all sorts of potential prevention interventions. So this is sort of just the thinking behind the Rome study. And I'm going to skip over just so that we have time for some questions. One of the big take homes from this young adult pilot is that a really large proportion of these young adults are using cannabis quite regularly, and thinking about the overlap between using cannabis, getting an opioid prescription, and how you're managing pain, I think is super interesting and is definitely a direction that we're going in. So I'm going to skip quickly through this information, and then I'm happy to share those slides with anyone who's interested in hearing more about the Rome study. But I wanted to just wrap up with some kind of high level thoughts about pain and substance use. So we know that pain is sometimes a motivator for substance use. So there's an interesting study out of WSU Vancouver that was just a survey study of young adults who use cannabis recreationally. And 40% of them report desire for pain relief as a primary motivator for cannabis use. And we also know that past month use, young adults who are using cannabis frequently are more likely to have misused prescription opioids. And use of prescription opioids, misuse is also motivated by a desire for pain relief. And then there's some national longitudinal data showing that adolescent chronic pain is associated with future opioid misuse. And among those individuals who have chronic pain, having trauma exposure and other substance use is contributing additionally to opioid misuse across that adolescent to young adult period. And I think there's a lot of shared biopsychosocial risk and learning processes that are at work in pain and substance use. So thinking about distress tolerance, and when we're thinking about parents, it's their ability to tolerate their own distress and their children's distress. Thinking about catastrophizing and worry, and fear avoidance. So when we think about fear avoidance processes in pain, they're very strongly related to pain-related disability. And this is just a sort of negative reinforcement through avoidant behaviors, very similar to the kinds of learning processes that happen in anxiety and panic. Poor social isolation and poor peer relationships are important in chronic pain development, as well as psychological inflexibility, and just the context of traumatic life experiences is clearly important in both of these areas too. So we'll just end with asking the question of, should you consider parent and or child pain in your work? So it is present whether you're assessing it or not. So just the prevalence rate in the general population, I think, is an argument for including it. Assessing pain is not that painful. There are promised measures of pain intensity, pain behaviors, and pain interference. And there's a lot of other key self-report measures that have been well validated that are readily available. So it's quite easy to assess things like pain catastrophizing and fear avoidance around pain, pain-related activity limitations. There's measures around stigma of experiencing chronic pain conditions, and also experiences of pain dismissal. And there's self-report measures of parents' responses to their children's pain as well. I think if you are assessing pain in parents, you want to keep that multidimensionality in mind. And keep in mind that parents' pain is really associated with all of these other risk factors. So thinking about it from that more broad perspective on parent functioning, not simply do you have a chronic pain condition, which may be sufficient for some things, but is also a little bit limited. So this is just a thank you to study participants and collaborators and our wonderful lab staff, who none of these things happen without. So I'm going to stop sharing.
Thank you so much, Dr. Wilson. That was just a wonderful presentation that really, as someone who hasn't directly studied pain in my own work, you made compelling arguments. So I really appreciate your presentation and the information you provided and the great work that you are doing. We do have a few participants still on. I can open it up broadly to questions. I'll just pause for a minute, and if to see if any of our attendees would like to unmute and ask a question or put it in the Q&A. And if not, I or other hosts here on the panel committee may have a few questions. Well, one of the questions I wrote down a couple notes. One question I had, and I don't think you said this, but I apologize if I missed it. Are rates of parent and child pain changing over the last 5-10 year, and or if so, or do we know that, and or if so, do we have some measurement issues?
Yeah, I think there is we have lots of measurement issues.
Mm-hmm.
I think when you're looking at these sort of epidemiological studies, a lot of them are not originally designed they're not designed with the sort of pain research world definitions in mind. Often it's really like a point prevalence of specific conditions that are chronic pain conditions, which is why you end up with such a huge range of prevalence. I think is really definitions are quite different. There's some evidence that adult chronic pain is increasing some. I don't know that is a surprise given just our general downward life expectancy, poor health trends that we have going on in the country. So I don't know that, but there's nothing that I don't think that there have been dramatic changes or increases over the past 20 years. So.
Thank you. It looks like Camille might have a question or comment.
Yeah, I was curious. I'm an early career investigator. I'm curious, like Leslie, I've not studied pain before, but I was, you made a compelling argument. I was like, oh, I should be including this more in my research. So thinking about sort of existing samples, we have some pain measures on some of the studies and not all of them, but what advice would you give to an early career investigator who's trying to be more intentional about including pain, or I even mentor some folks who are interested in pain research, but so what advice do you have?
Yeah, I think, well, I will say come on over to the pain research side because it's fun. I thought about in this talk, including a little bit of like, how does like a child clinical psychologist just become a pain researcher? But part of, I think, what has been really helpful for me is there is a really cool national and international network of pain trainees that was started by CIHR in Canada. It's called the Pain and Child Health Program. That's for child health, but it includes parents as well. And that group has a ton of awesome resources for trainees. I think the other thing is just realizing that like if you're trained to do behavioral and social science research, you're trained to study pain. Like it's not like rocket science, it's patient reported outcomes. And I think understanding that I think there are all of those NIH developed promise measures that are a good place to start. Because as a psychologist, I wouldn't have thought like, oh, I'm going to assess parents' physical function, or I'm going to assess parents' fatigue. That wasn't on my radar earlier in my career. Until you start working with these families and you see like, oh, there's a lot of just physical health experiences that are super important in families. And there's a lot of learning around that in families. So I think that we, as people trained as social scientists, have a lot of good perspective on those processes. And I would just say, don't be scared. Don't be scared to do it. And also you have people like me who are on the, on the P50, I'm happy to answer anybody's pain questions or like consult and say, this is what I would use to measure something in this study. So.
Thank you, Dr. Wilson. I know we're
Yeah.
at time here. Really incredible presentation and information. Thank you so much for
of course.
giving us the hour today. And thank you, panelists and attendees who joined us today. And just a reminder to finish the CEU, CMU, if that was something you were seeking from this webinar. And
all right.
Thank you.
Thanks, everybody.
Close out.